MY-QRUR conference call. My name is Corey, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Daniel Chipping. Mr. Chipping, you may begin.
Thank you, Corey. Appreciate the introduction. Welcome, everybody. We are very glad to have you all here today. But before we get going, I just want to introduce myself. If you're not familiar with Health Insight or me or Brooks, we'll just take a minute to introduce ourselves. Again, my name is Daniel Chipping. I'm a project manager in Health Insight, Utah. I've been helping physician offices in the northern area of the state mostly adopt meaningful use and work on PQRS, the Physician Quality Reporting System, as well as a number of other clinical improvement projects. And I'll go ahead and let Brooks introduce himself as well.
Okay, my name is Brooks McClellan. As you can see, I've got a master's in public health and health administration. I'm also a project manager, and I've been helping people in the Tooele County area, Summit County area, Vernal area, and central, Salt Lake and Provo in Utah to help them meet their meaningful use in PQRS and do other quality improvement projects. So.
And thank you, Brooks. And I just want to let everybody know that Health Insight is a quality improvement network and quality improvement organization. So those acronyms are QIN-QIO, if you ever hear us talk about that. That means we're a quality improvement organization across multiple states. So we have listeners and guests here, participants on the webinar that are from the states of Utah, Nevada, New Mexico, and Oregon, and those are the states that Health Insight serves. We do have a few other guests from other states who found out about our webinar and have come to participate, and we welcome all of you. We're grateful to have everybody here with us today. I just want to draw your attention to the chat function down in the bottom right-hand corner of your screen. If you have any questions during the webinar, go ahead and type in there. Feel free to chat with each other. If anybody knows answers to questions that another participant is asking, feel free to respond to each other and help each other with the knowledge that's being shared today. And we will answer at the last portion of our webinar. We expect to talk for the next 45 minutes, and then we'll have a question-and-answer portion at the end. And we'll start by addressing any questions that are in the chat box that haven't been discussed or resolved during the webinar. So, and finally, before I get going, I wanted to give a shout-out, a thank you to Qualis Health. They're another QIO in the country. And a lot of the material that we've prepared for you today was created originally by them from CMS information. So let's go ahead and get started. One more piece of housekeeping. I'd like to tell you about our Health Insight New Mexico office is accredited by the New Mexico Medical Society to provide continuing medical education for physicians. So we did make this webinar, we created it so that there would be CMEs attached, and Brooks and Ellen Pratt and Danielle Pickett are the people involved in creating the webinar, and Brooks and myself are the speakers and presenters. And for the continuing medical education credits, we do have to just acknowledge that we don't have any financial relationships to disclose at this time. So our webinar is going to cover three main topics. I will be talking about the first two. And so the first piece is just an introduction to the Quality Resource Use Report, the QRUR. The second is how to interpret your QRUR. And then Brooks will talk about the third piece, which is improvement strategies that you can take once you have the results of your QRUR. Now, I just do want to say that I think I realized that if I were to redo this webinar, I would give it a different title, and I would call it Life After PQRS. The PQRS is the reporting that you guys have been submitting and working very hard to understand, and the QRUR is the result of that. So we're going to dive into the basics and let you kind of learn and understand what the QRUR is all about. And to get us started, we like to have some interaction from the audience, so we've got a couple poll questions. And as those get pulled up, we'll give you about 30 seconds to answer these two questions. They are, did your office access your 2013 QRUR report? And I put PQRS in parentheses just because it's kind of the feedback results of your PQRS data that you've submitted. So we've got some results coming in. I'll let that build up here for a minute. Yeah, and we'll go ahead and broadcast those so you can see what people are responding as they come in, the live results. So we've got 13 people responding so far out of 37. We'll give it a few more minutes and let people respond. Make sure you click on one of those. Yes, you know your results. No, you don't. While people are putting in their results, I just wanted to specify that for the 2013 QRUR reports, groups of 100 received their actual QR report. Any physician office or provider group of less than 100 providers received a sample QRUR report. So there was no disincentive, no positive incentive tied to that, but the samples were sent to everybody so that they could all see what a QR report looked like. Okay, let's go ahead and close that. You can kind of see that there was a pretty consistent spread between people receiving and looking at that, and many who didn't, and probably a lot of people unsure about it as well. So we're going to start off by helping clarify a little bit so everybody understands what it's about. You'll hear it called the Physician Feedback Program as well. And the Physician Feedback Program is just a way to let providers and physicians' offices know how they're performing on a couple of areas. So with the QRUR is a report, one of the reports that comes as feedback to the physician office. And it contains information on quality of care provided to Medicare fee-for-service beneficiaries that the organization treated in 2013. So right now we're just talking about the 2013 QR report that everyone received. It also includes information regarding the resources that were used to provide that care. Again, CMS in 2014 of September, CMS provided these reports to all groups and physician solo practices nationwide who met two criteria. Criterion one is at least one physician was billed under the tax ID, and number two is the tax ID, the organization had at least one eligible case for at least one of the quality or cost measures included in the QRUR. Okay, so finally the QRUR is a report that helps you understand your value modifier score. It's based on the quality information that came in through PQRS as well as cost information that comes in through claims, and it leads to a value modifier score that will affect your reimbursement in the future. So the next slide is the Quality and Resource Use Report, which I will try to just say QRUR for the most part. Comes in a couple different formats. So in this year in 2014, we received the 2013 QRUR mid-year information, which is in the MY-QRUR, and the full year report will come out probably within a month or so to physician offices to give you an idea of your complete year of 2014 information. We've included a link on this slide so you can see how to obtain the QRUR for your own office. So feel free, when we post these slides, it'll probably be about 1 week from today's presentation that the slides will be online on the Health Insight website. You can go click on that link and pull up your own QRUR report. So we're going to talk a little bit about the differences between the mid-year and the annual QRUR so you're familiar with each of those. And while I talk about that, we'll just look at some slides that show the differences. So as you can see, the MY-QRUR is for informational purposes only. It provides interim information about performance on cost and quality outcome measured data pulled from Medicare claims. It's based on a calendar, not a calendar year. It's based on a time period from July 1, 2013 through June 30, 2014. And it does not contain information on clinical quality measures submitted through the PQRS program, as those were submitted at the start of calendar year 2015 for the 2014 period. It will not affect Medicare payments. It is not intended to predict future value-based performance. But you can see they do have a CMS calculated quality outcome score that can give you an idea. That's in the left-hand column under the MY-QRUR side. About 2/3 of the way down it says yes on Exhibit 5. So you do get that on the MY-QRUR. You'll see on the next slide that it also gives you some more information about costs, but you can see also that the annual QRUR is very comprehensive. So I'll talk a little bit about that. The A-QRUR includes benchmark information that allows each organization to compare its performance on each measure compared to their peers. It will cover the full performance period from January 1, 2014 to December 30, 2014. It will contain information on the performance on clinical quality measures and cost measures, which both feed into the calculation for the value-based payment modifier. Groups and individual eligible professionals will both be affected. Sorry, let me clarify a little bit. So the value-based payment modifier will be in effect for physicians in tax ID groups with 10 or more eligible professionals in 2016 based on their 2014 data submitted. Both groups and eligible professionals, smaller than 10, every size will be affected by their value-based payment modifier beginning in 2017 based on 2015 data, and all practitioners will be affected by the 2018 value-based modifier payment on 2016 data. And then if you remember a couple slides back, it showed also a supplemental QRUR. It's a confidential feedback report provided with information of Medicare fee-for-service beneficiaries based on episodes of care. It's generated, again, for informational purposes only. It complements per capita cost and quality information provided in the A-QRUR. So why is your QRUR important? And again, it's because the QRUR provides the comparative quality and cost data. The report previews some of the quality and cost measures that are used in the value modifier, and it will allow you to benchmark your performance against other providers. The Medicare Physician Feedback Program serves as the foundation for the value modifier, which will be used to determine whether an organization receives a bonus, a penalty, or a neutral payment for Medicare services provided. And again, this slide shows, it kind of highlights that the groups and providers are compared apples to apples. Measures are adjusted for risk based on the patient risk calculation and based on where they are geographically. So, sorry, I just lost connectivity for one quick second. Let's, we'll get the slides to advance on another computer. Yes, thank you. Okay, so the next piece is, let's look at the breakdown a little bit for the quality portion and the cost portion. Are we? Okay, we apologize, a little bit of technical difficulty. We tried to plug in to prevent this, but.
Is everyone seeing the how does your QRUR impact the value modifier slide?
Okay, if somebody could please type in the chat box and let us know which slide you're seeing. We may not be able to see the chat if our computer connection is down. Let me just double check with Chris. It looks like Brooks has the webinar still live on his computer. Can we make his computer present?
I am a presenter. I'm not sure if...
Share your...
Guys, I think you lost internet.
We just lost internet on our side for everything.
I can change the slides. I'm listening. While you guys get back
Okay,
on.
yeah. Okay, we'll have Chris, our WebEx presenter, if you don't mind, Chris, changing the slides, appreciate it, and we will move forward from there. So in the meantime, we won't see any chat come through, it looks like, for a few minutes, but we'll keep on going. So, Chris, I'll just ask you to forward the slide when I'm ready for the next slide.
And we're on slide 12 now, right?
Correct, we're ready for slide 12.
Yes.
So, slide 12, how does your QRUR impact the value modifier? We're going to talk about the quality component first. The value modifier is derived from a quality composite score and a cost composite score. The quality piece is a TIN's performance, or a tax ID number / organization's performance on quality care for Medicare beneficiaries across up to 6 domains. Each of these domains are equally weighted. The domains include clinical process effectiveness, patient and family engagement, population public health, patient safety, care coordination, and efficient use of healthcare resources. Something important to note is the number of measures is not equal within each domain. So for example, patient safety has very few clinical quality measures contained within it. Because all of the domains are weighted equally, the individual measures with the domains that have fewer measures will have a larger impact on the overall score. So if you have reporting capability on any measures that are sparse or few within a domain, those may be a good area to focus on, as it'll help improve your score. The next slide, please, is how the cost affects the value modifier score. And the cost measures across 2 domains, which are pulled from Medicare claims data, and those are the per capita costs for all attributed beneficiaries, and second, the per capita costs for beneficiaries with specific conditions. These conditions include diabetes, coronary artery disease, chronic obstructive pulmonary disease, and heart failure. Let's go to the next slide, please. You can see in this slide that there's an image that shows how the different domains contribute eventually to the value modifier score. So all 6 quality domains contribute to a quality composite score. The 2 cost domains contribute to a cost composite score, and both of those contribute to your value modifier amount. And again, just a reminder that it's compared relative to your peers. It's apples to apples comparison based on geography and risk adjustments. And if cost domain uses parts A and B claims data, part D is excluded. And if you qualify for an upward adjustment, you're eligible for an additional 1 plus 1x, which is a factor. It's not a percentage. We'll talk about that a little more in a minute. And that's if you're in the top 25% nationwide. The next slide, please. So the value modifier is calculated using quality tiering. It's an analysis to determine the type of the adjustment, whether it's an upward, downward, or neutral adjustment based on the performance of cost and quality. For between 2 to 9 eligible professionals or solo practitioners, there's a potential for upward or neutral value modifier adjustment of up to 2 factors. And for 10 eligible providers plus, there's upward or neutral or downward value modifier adjustments from -4% up to a factor of +4. And the next slide, please, shows an illustration of what that looks like. For high quality and low cost providers, the top performers will receive the largest incentive or positive payments by a factor of 2. High quality with average cost and medium quality with low cost will have a factor of 1 incentive. And the incentive comes from the providers who are in the yellow and red areas. So this is kind of a zero-sum game, is what some people like to call it. There's not additional money being injected into the system to give providers an incentive. the money comes from the providers who lose Medicare reimbursement dollars. So if you're a poor performer, if you have low quality and high cost, and you're losing 2% of your reimbursement, that money is going toward paying the providers who are doing better performance at a lower cost. And so that's why it's not a, when I talk about the factor, when you look at this slide and see the X next to the 2 or the 1, the +1 or +2, that means that it's a calculation based on the amount of money that was lost in that pool of providers who are in the red or yellow area, then that's distributed among the high performers. Let's go to the next slide and we'll talk about how to read the QRUR report. And let's see, that's the introductory slide. So next slide, please, is quality improvement feedback. And the PQRS value modifier reports have both quality and cost feedback sections. So the first section we'll see is a quality piece that lists each of your PQRS measures. If you look in column D, it will tell you the measure number. Column E tells you the description of the measure. F tells you the domain that it is within, and the reporting mechanism for column G. So if you reported via claims or EHR direct, or if you had a registry help you, that would show up there. And then it shows you your performance rate compared to the national performance rate. And so for some of these measures, you'd want to see that you're performing with a higher percentage, and some measures with how they're built, you'd want to see that you're performing at a lower percentage. So you'll just want to be cognizant, aware of that when you look at this report. Next slide, please. In Exhibit 5 of your report, you'll see the quality improvement feedback. And for all of the measures on Exhibit 5, which will be multiple pages, the first column you want to look at, again, is the performance rate. And you should determine whether your rate meets the quality goals that you've set for your group, and if it's high enough, again, when compared to the national benchmark. The next column you want to look at is the standardized score. It's the second from the right. We've got some red arrows pointing with some numbers circled. And these are the values that are averaged to make your total domain score. For this column, a 0 is average, larger than 1 puts you in the bonus territory, and less than -1 puts you into a penalty territory. So you should pay special attention to any measures where you are less than -1 or you have any negative standardized score. Let's go to the next slide, please. This is an image that comes from Exhibit 7. It shows how your average cost composite score compares to your peers. And in this instance, negative standardized scores indicate lower scores, so a better performance. And you can identify that, for all you cost people, you already know this, but for the rest of us, it helps to know that if your number is in a parentheses, that means it's a negative, and that shows improved or better performance. So you want your numbers to be negative in this, as it shows that you're saving money compared to your peers in these areas. A couple other things to note on this slide is we've got two main categories. We have one that says all services and one that says E&M services. So just wanted to point that out, that all services is everything other than E&M codes. Also, if any of these rows, for example, surgeons or medical specialists, are not applicable to you, there will be a 0 in the row or in those boxes, and it will not count against your practice. If you have, I'll mention it now, if you've got 30 days to review your QRUR reports when you get them, and you are able to request corrections to the report. The instructions come with the report when you download it. You'll be able to see how to request corrections if you need to. Let's go ahead and move to the next slide, please. Just to let you know, we do have our IT people working on our situation here. We've identified that we have internet connection, so We're wondering if maybe this is an Adobe issue, the platform we're using. I don't know, Chris, if you have people on your side who could take a look at it. Could be helpful.
Everybody has stayed connected except you guys, just so you know.
Everybody else is connected. Okay. Thank you for that. Appreciate that feedback. Okay, so the next slide, we're on slide 21, quality improvement feedback continued. This shows, again, cost scores. There's 2 scores being displayed. Number 1 is for all beneficiaries. It's for all the, and number 2, the second piece is for all the beneficiaries with specific conditions. What this report is basically telling you is how much costs did the patients incur inside and outside of the realm of care, outside of your practice is what it means. So not only the cost that is associated with a patient for claims that you submitted on that patient, but how much cost did that patient incur within the whole entire healthcare system for that time frame, if they had hospital admissions or they were admitted to the emergency department. Again, we're looking at apples to apples. It's risk adjusted based on geography, and the question that it's trying to answer is, did you provide enough care to keep the patient out of the hospital if at all possible, and did you avoid preventing too much care, like unnecessary imaging, unnecessary tests or procedures or treatments for that patient? So we'll go on to the next slide. This is a preparatory slide for what's coming next. Just want you to know there will be several graphics on the same page. We'll be looking for a red dot in the right upper quadrant, and that'll kind of show you where you are compared to others. We'll be looking at also kind of a speedometer gauge in the bottom left-hand corner. Let's go ahead and take a look at the next slide. So let's focus first on the top right-hand corner. This is what it looks like in the QRUR report. They don't have the table that I showed you that has green and yellow and red, but you can tell that it has the similar quadrants. So where the red arrow is pointing is the quadrant that you want to be in, the high quality at low cost. You'll see on this image that the person or the practice being represented has a small red dot that's slightly toward the left, kind of in the middle. And that indicates where that practice falls in comparison to their peers. Where you want to be is in that top right quadrant if you want to receive the incentive payment, or at least be in the yellow areas where you're avoiding penalties. And then the dashboard on the bottom left that shows the speedometer image shows if you're in a yellow, you're in a neutral payment. If you're in a green, you will receive a positive incentive, and if you're in the red category, you'll receive a negative incentive. They've really tried to make it helpful to show you in a number of different ways how your performance compares and what you'll be able to expect in the following 2 years when your incentive/disincentive is applied to your reimbursements. Finally, the next slide is just, again, a synopsis or just a revisiting of the quality domains that contribute to your quality score, the cost domains that contribute to your cost composite score, and how both of those go into your value modifier. So important things to know. Just a reminder that if you qualify for the upward adjustment and you're in the top 25% nationwide, you're eligible for an additional +1 factor on that incentive payment. So the next piece is going to be Brooks, and we can move to that next slide. And I will let him take over and teach how to use the report for improvement.
Great, thank you, Daniel. I'm on slide 25, so I'm going to be talking about the quality improvement strategies we're going to want to use to track and get credit for the great things you're doing. You're already providing great care, and if you can track that through your EHR, you're going to be light years ahead of your competitors. So we're going to look at strategies around all of these areas. As you can see, we've got the 6 domains for PQRS, and then at the bottom, we want to advance to slide 26. And so we've got the 6 domains, and we're going to also look at the cost measures and see how we can, which apply to the cost side of your value modifier score. So let's go to slide 27. This is our first domain, which is clinical processes and effectiveness. And so for this domain, well, the quality improvement reports is something that you'll want to monitor on all of the 6 domains. This is something that could apply all over. You're going to want to make sure that you provide quality improvement reports that give meaningful feedback to your clinicians, especially your providers. And you're going to want to provide someone who is an expert at providing these reports and showing the data. Usually it's most effective to show the data as a comparison side by side so they can compare themselves to their peers and their coworkers. And if they can see Dr. Johnson is doing so much better on this measure than I am, you can go talk to him or just watch what he does. And usually the competitive juices get flowing and people improve pretty quickly once they have reliable quality reports. And sometimes people will get reports that come back with 0 numbers or way lower than what they know they're doing, and usually that just means that they're entering the data in the wrong place in the EHR. So work with your EHR, make sure that the quality reports are giving meaningful feedback and that you know where to enter the data so that all of your patients are represented as you're pulling these data reports. Another effective way to improve your clinical processes and effectiveness is by running lists. You can do this by care team around diabetes and ischemic valve disease. You can run lists for your women who are older than 67 and see which ones have had a bone fracture, make sure that they're getting screened for osteoporosis and follow up for that. You'll also want to make sure that your women between the ages of 50 and 74 are up to date with their mammograms. And you also want to make sure that you run lists of patients according to race, ethnicity, and language to see if there's any care disparities or care gaps among those groups. You also want to make sure that you schedule time and give people enough time not only to provide these reports and work with your EHR and talk with the providers to make sure that they believe the data and that that's meaningful for them. Because if they don't believe the data, then they're not going to, obviously they're not going to feel like it's helpful in helping them reach their quality goals. And so also give your teams time to review the reports and set goals and look at ways that they can modify their workflow to improve on their clinical effectiveness. All right, let's move on to the next domain, which is patient and family engagement. As you can see here at the top of the slide, I've got a link to the AHRQ Guide to Patient and Family Engagement in Quality and Safety. And this guide suggests 4 steps to helping your patients and families become engaged and how you can formulate intervention. Step 1, identify opportunities for patient and family engagement. With this one, you already know this. You've worked with your patients, or your providers have, and they know the things that they wish their patients would do in order to be more engaged and be more proactive about their health and things that would really benefit them and their families. And you can take those ideas and opportunities to leadership and going on to step 2, get the commitment and the support from them to help get the resources and the time to really take on a project to help improve your patient and family engagement. And also to promote among your coworkers and colleagues the importance of these opportunities and the efforts that you're using to provide an effective intervention around patient and family engagement and help make them aware of what's going on. And so then once we've done that, we'll go to step 3 and form a multidisciplinary team. You want someone from all areas of the clinic, the front office, the MAs, the providers, and the administration, to all have representatives on your team that will help you plan and implement the strategies. And most important, you're going to want your patients and families to be invited to these planning meetings to help give you input on what would work for them to help them be engaged in these efforts. The AHRQ guide has some handouts that you can provide to your patients to see if they would be willing to sit in on a family engagement team to plan some of these strategies. And this will go a long way as they see that you really care about improving your quality and see that you care about what they want and what they would like to see within your clinic. And then step 4, you can look at implementing and evaluating your strategies. So this is where you'll take your plan that you've made and you'll incorporate a PDSA cycle, the plan, do, study, act cycle, where you take your plan and you implement it on a small scale. You might want to just do it with a couple of patients or for an hour in the afternoon or with one provider and do a test of this change and see if it actually works. Does it cause problems? How can you fix those problems? And then work out those bugs and try it again. And as you find something that works, expand it and do something on a broader scale. Maybe do it for a day or something for the afternoon among the whole clinic. And make sure that it works on that scale. And then once you've found something that really works, then you can implement it throughout the company and have something that's a meaningful change for you and your patients. All right, so now let's go on to population and public health domain. So here we want to make sure that we have adopted protocols and workflows that reflect the most recent guidelines for tobacco screening, cessation counseling, and all the screenings and follow-up that you're going to want to provide to your patients. As you can see here at the bottom of the slide, there's the U.S. Preventive Services Task Force. This is a link to just one of the tools that you can use to make sure that your screenings and your workflows are up to date, that you're following recommended evidence-based guidelines to provide these services to your patients. Okay, now let's move on to patient safety on slide 30. So first thing here is you're going to want to make sure that you're getting credit for what you're doing. Have your coders study the measure specifications. I've got the link here. And the measure specifications will help you to get credit for the patient safety efforts that you do. Also, you're going to want to utilize your drug formulary and clinical decision support to help minimize the use of high-risk medications. These will help to suggest other medications that would also be appropriate, or just give a warning alerting you this is a high-risk medication, you may want to consider using a different medication. And so to go along with that, you're going to want to make sure the list that you have of the high-risk medications is up to date, and you can do that on the MY-QRUR website, and you can see I've got a link here. And this link will take you to it's a list of lists, and when you get to this site, you're going to want to scroll right to the bottom. The bottom 3 lists are the lists that you're going to want to look at with the high-risk medications, that you can make sure that your clinic is up to date and knows which medications are the high-risk medications. Also, for your patients that are on warfarin, you'll want to check their INRs frequently and make sure that their INRs are within the therapeutic range. If they're not within that range, then you can consider shorter retest intervals, or patient self-testing to help them monitor and stay within the appropriate range. Okay, let's move on to slide 31, care coordination. So you're going to want to track your patients who have a diagnosis of mental illness and follow up with them within the 7 or 30 days. And you also want to make sure that you've got their problem list updated regularly. You can also incorporate a system into your workflow to flag your high-risk patients and document their follow-up. Checklists can be used, which is helpful to make sure everybody has had all of the follow-up items associated with their condition addressed. And this will also help to reduce errors and waste. Care management or care managers can be helpful in following up with these patients and tracking these patients. They can also help with creating strong relationships with your local hospitals and urgent care facilities, and maintain communication mechanisms with them so that your clinic is notified when they are admitted, when your patients are admitted or discharged from the hospital. And it's also a good idea to take a field trip with your care team to go and meet the people at the ER and at the urgent care, and get to know them and promote working together as a team. Okay, let's move on to slide 32, efficient use of healthcare resources. The name of the game here is eliminating waste. What you're going to want to do is create a regular process for checking whether your orders and tests are necessary for your patients, or if they're just extra tests that weren't necessary, and make sure it's appropriate. The Choosing Wisely site is an initiative that helps give resources around this subject. You can use this resource. As you can see, I've got a link to the site there, and read up on what the evidence-based guidelines are for when you should order certain tests and procedures. And you can use these to validate your protocols, make sure those are up to date. Another thing you can do is provide a 24/7 way for your patients to get answers to their questions, either through a phone line or secure messaging in your patient portal. This will help them to avoid unnecessary ER visits or urgent care visits, and help them. It's also helpful to have a protocol for your staff that's answering these phone calls, so that they're all on the same page and giving sound advice about how to use these high-cost, high-risk services. All right, let's go on to slide 33 and talk a little bit about the cost measures. So here this is going to be the cost. So we're leaving the domains of PQRS and we're going to the cost side of your value modifier score. And this is how you can use your QRUR report to examine how you're doing on your costs. And so you can use your exhibits within the QRUR report and to identify high-cost providers and those with high readmission rates, and talk to those providers, maybe compare what they're doing to other providers in your clinic that are doing a little bit better, and strategize on how they could better lower their costs around these areas. You're also going to want to get with your billers and make sure that they are coding diagnoses robustly. This helps by showing Medicare that your patients, how complex your patients are. If you're showing all of the conditions that they have and all the things that they are dealing with, then they will be able to see the reasons why you're ordering certain tests, and as they look at your patient population, they can risk adjust your score appropriately so that you have more leeway to order these tests and not get dinged for those. You can also use your exhibits in your QRUR to identify high-cost patients. Look for those patients who are utilizing the emergency room and urgent care a lot, and look to see if there's more appropriate opportunities for them to get the care that they need, but maybe not such high cost care. And you can encourage all of your patients, especially the elderly, to have their advance directives so that they can express their end-of-life wishes, and working closely with local palliative and hospice providers also helps to lower your costs as well. All right, let's move on to slide 34, the cost reduction strategies. This is just a summary slide. I just wanted to reiterate that improving your quality and doing prevention through population care management and managing your care transitions is going to help you reduce unnecessary spending and improve care at the same time. Sometimes we have providers who say, well, this is just going to motivate people to not give the care that's needed, and we can't think of it that way. We have to think of it as, you know, we need to do the appropriate care at the right time so that in the long run, the patient will not go to the emergency room and will not be admitted into the hospital. We keep them as healthy as possible, so we do the appropriate care that will help them to be healthier and happier patients. Okay, so now let's talk about the future of quality reporting. And I've got a silly poll here. But on slide 36, it says, what do you think is the most likely to happen in the near future regarding value reporting?
Chris, are you able to pull up the poll for us?
Let me see if the poll is on there. Is this the first poll? Yes.
This is the second poll. Or poll number 3, excuse me.
Sorry.
No problem.
The poll is open.
Okay. All right. The poll is open. So what do you think is most likely to happen in the near future regarding value reporting? A, we're going to go to universal health care. B, quality reporting will go away. We won't have to worry about meaningful use or PQRS ever again. C, we can finally go back to paper charts. Yay. Or D, there will be a roll-in of all programs into one value-based payment system.
Guys, I think I had the wrong. The poll is now open again. It was poll number 4. I apologize.
Sorry about that. Okay. Thank you.
It is open.
And I can't see the results. I guess we'll take a minute.
Yeah, I will let you know the results, and you can see them on the archive as well.
Okay. And so let's go on to the myths. I guess we'll.
Most of the participants believe D, with a couple believing A.
Okay. Good. You guys are smart. It was D. I just kind of had that for a silly little poll to hopefully get people awake. So here on slide 37 is the merit-based incentive payment system, and this is the future of these programs. Coming in 2017, so just not this January, but next January, we're going to have a roll-in of all of these programs, meaningful use, PQRS, and the value modifier, and they're going to be streamlined into one value-based program. And let's move on to slide 38. The MIPS program will have 4 performance categories ranging, and the score will range from 0 to 100. Meaningful use will be worth 25 points. Quality will be worth 30 points. Resource use will be worth 30 points. And clinical practice improvement will be worth 15 points. And this will determine your payment adjustment. If you have a high value score, you'll get a positive 4 to 9%. If you have a low value score, you'll get a negative 4 to 9%. And then through the year 2024, If you're one of the highest performers, then you can get an additional 10% on your Medicare Part B reimbursement. So that would be a positive 19% on your Medicare reimbursement. And again, it's going to have a 2-year adjustment. So like if you're doing MIPS successfully in 2017, the payment adjustment will apply to your 2019 Medicare reimbursement. All right, and so your QRUR or your quality improvement organization like Health Insight will be who you want to work with to help you improve your QRUR report. Please contact us. Here's some resources and tools on slide 39 that you can use, and also slide 40 that will be helpful. Let us come and help you work through improving your QRUR report, and we've also got a number of programs that can help in a number of quality improvement areas. On slide 41 is our contact information for Daniel and myself. If you're in the Utah, Nevada, New Mexico, or Oregon, then Health Insight is your quality improvement organization that offers subsidized help for improving your quality and complying with these programs. If you're outside of those states, feel free to contact us and we'll help you get in contact with your local quality improvement organization. We'd also like to give a special thanks to Qualis Health for letting us use their 2013 QRUR Interpretation and Quality Improvement Guide. We're also going to have that available on our website as well when we have the slides in about a week. Just a heads up about September 17th CMS National Provider Call about your 2014 QRUR report. And this report will be available later on this fall, so it probably will be available pretty soon after this September 17th date. And you can register for this call at the link at the bottom of this slide. Now it's time for questions, but before we go into that, I just want to direct your attention to the chat. There should be a link to a survey that you can use to give us some feedback about our webinars and how we can improve these, and hopefully we can provide the information and the resources that you need to be successful in these. So now
Brooks, you might tell people to go ahead and move their cursor all the way up on their chat, since that was the first chat entry to get to that link.
Oh yeah, go to the top of the chat section and there's a link for that survey. And it's only going to take a couple of minutes because there's only a few questions, and please give us some feedback to help us improve these. So now let's open the phone lines for questions, and we'll take a few minutes to answer those.
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a